Hi team, a little review on oxygen therapy and mechanical aids to supporting respirations. This is Kriss Ghafourpour, one of your training sergeants. Let's get going. As always, our baseline fundamental principle is to be always ready, to know our objectives, plan meticulously, which includes training, be ready for changes in conditions and awareness of what is happening so that we can adapt to the ever-changing evolutions that we experience. Those of you who are Virginia Beach Marine Rescue Team members will have the opportunity for a $5 gift card challenge by answering the test questions that pop up on the slides that will have these particular icons. Write down your answers, send them to me in email, and we'll check to see how well you did, and you will be offered a $5 gift card for your time. One of the most important steps in what we do in every evolution is being situationally aware. In the international progressive testing regimens that EMTs and paramedics go under, there are two main facets that are always step number one in their algorithm or recipe to treatment. Number one is the scene safe? And do I have the proper PPE for that evolution? Go over the list on the right side. Here's a situation where there are lessons to be learned. A partner of mine that is now working for the CHB, California Highway Patrol, had responded to a single vehicle accident near the Golden Gate Bridge. These are the considerations that you must put into play. Is the scene safe, and what kind of PPE do you need as you approach this car? List 4 things that you should do as you are making your approach. As the first officer on scene arrived and approached the vehicle, they saw a single driver, male, slumped over the wheel. He immediately called in for additional help. We have one unconscious driver. Read over this sit rep and see what lessons there are for you to put into play if you were to approach or come onto a scene just like this. How could they have prevented the situation that arose unexpectedly? As a baseline to our training, we always try to fill in that gap of what we don't know, we don't know. That's what we're here to do today. Regardless of your level of training, this course is for everybody on our team because you need to have an understanding of the delivery systems we carry and be able to feel comfortable and confident in setting them up, because you may be the assistant to the primary person delivering the aid to our patients. Our goal then is to understand what we carry and get comfortable and confident in setting the pieces of equipment up properly. Our objectives today will be to explain the advantages and disadvantages of the various types of airways and breathing adjuncts, to understand the purpose and procedure and the significance of using these, especially the suction, and learning new terms and concepts. It's important as you come on the shift to start playing around with some of the equipment that we have, especially things that help monitor vital signs like the blood pressure cuff and the stethoscope. Again, you may not be an EMT or paramedic, but you'll be the key person possibly to reassess vital signs as the primary person is assessing and managing the patient. You must experience the range of normal of vital signs so that you will be able to identify what is abnormal. So take a chance to utilize our vital sign equipment. Knowledge quest question. Why are baseline vital signs so vital? What are the vital signs you must measure and record? In our line of work, we must not just assess things, but we have to be able to document this for our patient reports. We want to be able to document respirations, pulse, blood pressure, and when appropriate, necessary, temperature. That said, what is the fifth vital sign? Another knowledge quest question. Appropriate assessment requires a keen sense of attention to detail so that you can use your sight, your smell, your touch, and your hearing to assess your patients. Notice that a lot of this doesn't require even hands-on. It's just observing the patient. As we mentioned, it is important to practice these techniques because practice makes mistakes that you can correct so that you can gain the confidence in order to do it in the heat of the moment. Some important facts for people on marine rescue to know and understand and appreciate. Here's a knowledge quest question. How much does water weigh per gallon? And then calculate how much does that water weigh in a cubic meter. Here's an example of why that knowledge and respect is important. The day before I came on shift at Station State, Golden Gate, where I was a Coxswain 47, the team previous to that day had taken out the 247s for training in the surf. The one boat was knocked over or rolled in the surf, causing significant amount of damage. As you can see, what it normally would have looked like on the left side compared to what it looked like after coming out of the surf on the right side. Notice that the entire upper structure with the radar and electronics was knocked off. If you look closely, you'll see a lot of the metal pieces, including the chairs, were flared and pushed outwards. That is all because of the weight and pressure of the water. Now let's focus on respirations. Respirations are the peripheral measurement of the rise and fall of the chest during a cycle. Each set of rise and fall is considered one respiration. The method for inspecting and looking at your patient's respirations is visual, really. And it's important not to let them know that you're counting their respirations because respirations involve voluntary and involuntary controls. If someone tells you they're monitoring your respirations, you may alter them without paying attention to what you're actually doing, which will cause a falsification of the numbers. So best thing to do is count without telling them for 30 seconds and then multiply that 2, and that will be your respirations per minute. Question, other than rate, what are other assessments of respiratory character that you can gather from your patient? Here's a mnemonic to help you assess your patients. Look at how they're breathing. Is there any abnormal odor to their breath? What is the rate, as we described? What is the depth? Any abnormal noises? The ease at which they're able to breathe, and the rhythm. The mnemonic here is hard air. If you know to these, you'll be able to assess the norm from the unnorm. You or I, as average adults, will range our respirations between about 12 to 20 at rest. Because of the metabolism of a smaller body, such as an infant, they will breathe about twice as fast. A typical adult cycle in and out is 1,000 cc's, so 500 per breath in. Knowledge quest question. For an infant that is not breathing but has a pulse, What is your intervention for rescue breathing? It would be 1 breath every how many seconds? In medicine, for various reasons, it's important to document our assessments for our patient reports. So don't forget to take note and document the respiration cycles per minute. Make any remarks about the characters that we talked about for the mnemonic hard air. One example would be to say patient's breathing 32 times a minute with expiratory wheezes, i.e. they have a high-pitched squeal when they breathe out. On a visual graph, here we can look at frequency, amplitude, and character of different types of breathing and what they're called. Assignment, you were also given a handout. The slides that are corresponding to the handout will have the handout page number on them for you. Let's look at oxygen equipment. Oxygen is carried in tanks. There are various tanks available. For us, in our portable green bags, we carry D-size oxygen tanks. Those have the capacity of about 400 liters that is compressed in a gas. Because that gas is compressed, it's under very high pressure. Generally, a full tank will register 1,800 to 2,000 psi. These tanks are under high pressure, which requires you to have a regulator system to reduce that pressure in order to be able to assess it on a gauge, and then reduce it in a secondary regulating system to give out a slow level of line pressure that would then give the oxygen gas to your patients. So there's a single stage coming off the tank and a second stage coming from the flow meter. Those of you who are qualified will be asked to check our O2 tanks at the beginning of your shifts. You don't want to find out in the heat of the moment that your tank is empty. No doubt, in the last few years, at least a handful of times, I found empty tanks at the beginning of our shifts for various reasons. We'll talk about some of those. So your tanks do need to be checked at the beginning of your shift. Question is, does it run the tank dry to check it and waste that little amount of oxygen? Test question. How many times can you check a tank before it is half full? I.e., if a full tank is 2,000 psi, how many times can you check it before it's 1,000 psi, which is our protocol for when we want to change our tanks? Measure this. Each time you check your tank, you will not lose any more than 40 cc's of oxygen. If half of a D tank size that carries 400 liters, half of a tank would be 200 liters or 1,000 psi. If you're checking it and you're losing at most 40 cc's, that will allow you to actually check a tank 500 times before it hits the threshold of needing the tank to be changed. So don't be concerned. It's much better for you to check your tank at the beginning of your shift and make sure you're ready to go for the day. For those of you who are trained, you may notice that there's something wrong in this situation. One morning when I came on, I checked the tank and it was leaking. If you look closely, can you pick out why the tank is leaking in this case? This is a knowledge question. Again, look closely and figure out what's wrong in this case that caused the tank to leak. Note, understand that all tanks under pressure need to be inspected visually and also put into high pressure water to make sure that they are feasible and mechanically stable to be able to be used continuously for the purposes that they were made for. For us, in medicine, the oxygen tanks need to be inspected every 5 years. The visual inspection requires a professional to look with fiber optics inside the tank looking for any rust. Generally, the gases are dry. However, if the mechanism that the gas was filled in had any hydration in it, rust will occur and weaken the tank.
BSI on. Now my patient is experiencing difficulty breathing, so I want to go ahead and get this tank working. So, got my regulator. I'm going to go ahead and set the tank up. So when you have a new oxygen tank, you want to bleed the tank. Now the air is going to come out of here, so take caution, make sure this isn't pointing towards anyone. And I have my plastic wrench. So you're just going to bleed it just a little bit. That's all you need to do. I have my regulator all set to go. My cap is already in there. And I'm going to take these two prongs and place them right into those two holes. So after that's on, nice and tight, I got my plastic wrench again, and I'm going to open it up all the way. And then I'm going to go back one round. Now as you can see, we are up to, let's say, 1500 PSI. So we have enough in here. Remember, you never want to let it go below 200 PSI. So we want to hook up the oxygen mask. What we're going to do is take the end of the tubing to the oxygen, put it on there nice and firm, and with a non-rebreather, I'm going to put it up to 15. You see we're at 15. And now, to fill up the mask, you're going to just push into here and the mask will start blowing up. And you'll go ahead and put it on the patient. So to put the mask on, just going to go around the head. And obviously our patient doesn't like the mask. So the patient is not tolerating the mask. So what we want to do is turn it back off and put on the nasal cannula tubing. Works the same way, except for nasal cannula, you're only going to turn it to 4 to 6. For right now, we'll put it on 4. So now we have the nasal cannula hooked up at 4 liters per minute of oxygen. How we apply this, it goes right into the nose, around the ears, and we can tighten it right at the neck. And that's how we apply a nasal cannula.
I feel better.
Oh, good. So she wants to go ahead and sign off, so we're going to go ahead and remove the nasal cannula. And discontinue oxygen therapy. So when you want to discontinue, we'll turn that off, unplug the oxygen tubing, take my plastic wrench, we'll go ahead and tighten it back up. Remember, righty-tighty, and we know that we're going the correct way because it took us longer to go around. So now that the tank is closed, we want to go ahead and bleed the tank so that we know all the air is out of the regulator and set. And we can go ahead and take off the regulator. And that is oxygen therapy.
I've told them 1,000 times not to leave the tanks upright. Someone should really take care of that.
No, they all suck.
That's
so dumb.
Why are we part of the fire department?
Just an important side note to keep in mind and try to do every shift. Our zippers on our med bags and other device bags get corroded from the condensation of the saltwater air, and there are multiple times where the zippers get stuck and they will not undo because of the buildup of various salt particles and corrosion. So please get in the habit, even if you're not fully checking the equipment because you're not certified to do the oxygen treatment, please do move the zippers around, because when they're stagnant and they sit in one place, they will get fixated. Okay, let's review the BLS airway and ventilation methods. It's important to understand the definition of supplemental oxygen. It is when we're using an adjunct device connected to our oxygen delivery tank that will increase the fractional percentage of available oxygen the patient would be breathing. If you're just breathing oxygen from the air in the atmosphere, you're getting about 21%. If you have a decrease in your ability to ventilate properly, certainly the percentage of oxygen necessary for survival drops. So what we try to do is give the patient supplemental oxygen, additional concentration of oxygen, and each device delivers a different percentage. So the objective then is to maximize the amount of oxygen that the blood cells take in. So what do we carry? We just try to keep it simple with a nasal cannula and a non-rebreather mask. However, there are a variety of other things that the paramedics or other units may carry, including nebulizers, a way of vaporizing medicines for patients to breathe, for example, in an asthmatic attack. Let's watch this short video.
Hi, my name is Nick and welcome to this 5-minute lecture on the basics of oxygen delivery. It hopefully comes as no surprise to you, but occasionally our patients require more than the standard 21% of oxygen that we find in fresh air. There are a few different ways we can deliver supplementary oxygen to our patients, but how do we decide which device to use? Current thoughts on oxygen is that we should give just enough to allow a patient to have a normal oxygen saturations. That's normal for them, so for a healthy young person that may be 97 to 99%, for an older person it may be 94 to 97%, and for a patient with a type of COPD who relies on hypoxia rather than hypercarbia to drive respiration, 88 to 92% may be acceptable. Oxygen flow rates, not percentages, are controlled via the oxygen port attached to either an oxygen cylinder or piped oxygen through the walls. In the UK hospital, oxygen cylinders are usually black with a white top. Nasal specs are a nice way of delivering small supplementary amounts of oxygen to our patients. They have the advantage of being more comfortable and more convenient than a mask and allow the patient to eat and drink while still getting extra oxygen. The disadvantage of nasal specs is we can't really deliver a high rate of oxygen, so we can only use it for lower levels of supplementary oxygen from 2 to 4 litres a minute, which equates to approximately 28 to 35%. The simplest type of oxygen mask relies on the flow of oxygen to deliver the percentage of oxygen required. The higher the flow rate, the higher the percentage of oxygen delivered. That said, it's not very accurate. The faster the patient breathes in, the more air is entrained via the sides of the mask and mixed with the flow of oxygen, diluting the oxygen that's inhaled. Venturi masks are a good way of controlling the percentage of oxygen being delivered, but also allowing higher flows of oxygen-air mix. Each Venturi valve has a percentage of oxygen on it and a flow rate required to deliver that percentage. The valve has small slits in the side through which the flow of oxygen down the middle drags air in to equalise the pressure differential. It is known as the Venturi effect, and because this effect is calculable, we know how much oxygen is being delivered. To change the level of oxygen, change the valve, which come in a variety of percentages from 24 to 60%. The flow of oxygen is very drying, and one way of overcoming this is to use humidified oxygen via the system you see here. The percentage of oxygen is controlled by this adjustable valve and the flow rate using the same Venturi effect, but in this case the oxygen is passed through distilled water to humidify it. The downsides, it's noisy, it's wet, and it has to be changed regularly due to the infection risk. So what do we do with a patient who needs more? Well, we can use a non-rebreathing mask, which is like a normal oxygen mask but has a reservoir bag. We've already discussed that with a simple oxygen mask, air is entrained in via the size of the mask, as we tend to breathe in much faster than the flow of oxygen. The non-rebreathing mask gets around this by having a reservoir full of oxygen for the patient to draw on. Although some air is still entrained using this method, we can deliver up to 85% oxygen to our patient. For the non-rebreathing mask to work, the reservoir bag must be inflated before use, we must use 15 litres flow of oxygen, and the mask must be tight-fitting to draw oxygen from the reservoir bag and limit entraining. Any patient requiring this level of oxygen has something wrong with their oxygen uptake and requires specialist referral. This method of oxygen delivery is not supposed to be a long-term thing. The final thing I want to talk about is not a device for delivering oxygen, but a device for delivering certain drugs, the nebulizer. The nebulizer has a chamber where liquid drug is put. Air or oxygen is then passed through this chamber, which turns the drug into a fine vapour to be inhaled by the patient. You will struggle to get the flow of oxygen or air in a nebulizer much above 8 litres per minute, as the back pressure from the chamber will cause it to blow off the wall. Well, that's the basics. Thank you very much for listening.
Well, it's important to go over those different devices because you may be asked to set one up for a paramedic in a specific case based on what they bring on the boat for us to utilize in an emergency. So now let's loop back to the two devices that we actually carry. The nasal cannula. I'm sure you've seen people out and about shopping carrying a small little oxygen tank with these devices on their nose. Realize that if someone is in real distress and unable to breathe, they're breathing mostly through their mouth. So this device may not actually give them the oxygen that they need. The key thing for us to remember is for us to utilize this device, the oxygen tank flow meter is set somewhere between 2 to 4 to 6 liters based on your understanding or the direction from the paramedic. The device that we carry is the non-rebreather. The idea behind the definition of this is that there are valves on that mask, so if you look closely at the diagram, that allow air to escape but not allow air to come in. So the patient is not rebreathing their CO2 as they expire. With the reservoir, the bag that hangs in front of the mask, as that fills before you put that over the patient's nose and mouth, they will draw in a certain volume in their distress phase, which is normally more volume than they would at rest. Hence, that reservoir helps meet their demand for inspiration. That being said, the oxygen tank delivering 100% oxygen into the tube will mix with atmospheric oxygen and drop the percentage that the patient's getting to about 80 to 95%. However, in order for that to be effective, you have to set the flow meter on the second stage of the regulator to 15 liters per minute. For the knowledge quest, what was the purpose of the one-way valves on the mask? We just mentioned that in the previous slide. So it's easy to forget that the small D-sized tanks that we use obviously can't run at a high volume forever. So another knowledge quest question that you can easily look up on Google is how long will a D-sized oxygen tank last if the flow meter is set at 15 liters per minute? Remember that the D-sized tank has about 400 liters in the tank when it's full. Continuing on the topic of ventilation and respiration, don't forget that the new algorithm for CPR, or assessing your patient, is CAB. Checking for circulation and life-threatening bleeding, assessing the airway, making sure the person is breathing, and simultaneously checking their pulse. If the patient is unconscious, has a pulse, but is not breathing, then you would do rescue breathing. If they're unconscious, breathing, and have a pulse, you would want to put them on their side in the rescue position. Have suction available in case there's any vomit or secretions that need to be suctioned to maintain their airway. Recall in your CPR class that there are different ways of opening the airway in an unconscious patient. You could use the head tilt chin lift. If there's any concerns about C-spine injury, you would use the jaw thrust. And when you ventilate, if you can't get air in and you don't see chest rise, you retilt and reposition and try again. If once again you have difficulty ventilating, then you can try to tilt the head slightly 30 degrees in that sniffing head tilt chin lift position, and sometimes that allows air to move into the lungs better. For professional rescuers, in order to give positive pressure ventilation, we have adjuncts available to help us do that better. There are, of course, rescue masks, generally with a one-way valve. There are bag valve masks, and there are other mechanical aids to help ventilation. Remember, in our professional capacity, we don't want to be doing mouth-to-mouth resuscitation. We want to use an adjunct to reduce and nullify the possibilities of germ transfer and infection control. In its crudest form of infection control, the rescue mask is a very simple airway adjunct to help ventilate because of its inflatable cuff that helps seal around the nose and mouth. Again, it has a one-way valve to help reduce the movement of particles from the patient to you as you're blowing in the inlet. However, we don't utilize this method because there's better ways to do it and to reduce infection risk even more, which is the BVM, or the bag valve mask. Let's watch this short video.
There are many types of face masks, varying in design, size, and construction materials. Transparent masks are preferred because they allow for inspection of lip color, condensation, secretions, and vomitus. Face masks consist of three parts: the rim, the body, and the connector. The rim of the mask provides the seal with the face. Many masks have an inflatable cushioned rim, which creates a better seal with facial contours. Some masks have a malleable body, which can be molded to the face, thus reducing dead space. Masks equipped with a ring with hooks can be used with a mask strap to better hold the mask on the face, but may prevent rapid removal of the mask, for example, when suctioning the oral cavity is necessary. The connector of the mask is a standardized 22 mm diameter orifice and connects the mask to a bag valve device. To maintain a good seal, it is imperative for the mask size and shape to conform to the facial anatomy. This is particularly important in the pediatric population. Thus, several mask shapes and sizes should be readily available. There are a variety of bag valve designs available. All have a self-inflating bag and a non-rebreathing unidirectional valve. The valve is designed to function during both spontaneous and manually controlled ventilation. Because bag valve devices can operate without an oxygen source, it is important to ascertain that supplemental oxygen is flowing through the bag valve device when indicated and available. Bag valve devices can be equipped with an oxygen reservoir of varying design. If the reservoir bag fills, oxygen is flowing. Oxygen flow through bag valve devices with a tube reservoir can be confirmed by listening to the sound of gas flowing. The purpose of these reservoirs is to maximize the delivered oxygen concentration. A bag valve device's capability for delivering positive pressure ventilation should be tested before use. This can be achieved by sealing the bag valve device connector with the thumb and squeezing the bag with reasonable force. If it is difficult to compress the bag, or if air is forced between the connector and the thumb, positive pressure can be delivered. Whenever possible during face mask ventilation, suction should be readily available. Airway management adjuncts such as oral or nasal airways may need to be used.
Here's another knowledge quest question for you that you can look up. When we breathe in 21% oxygen from the atmosphere, what percentage of oxygen do we expire? So there are many different sizes of bag valve masks based on the population and age of the patients that you may need to resuscitate. Most importantly, per the protocols, you only need to oxygenate the lungs or ventilate the patient as much as you see the chest rise. It's very important not to push beyond that and not to overinflate. Pushing beyond it will cause barotrauma or trauma to the tissues that will result in an end-stage issue when the patient is recovering. Too much pressure will cause air to back out from the lungs, the trachea to the esophagus, and will fill the stomach with air, which will cause one of two issues, either restricting how much you can ventilate because now the stomach is full of air, lessening how much you can ventilate the lungs, or the gas in the stomach now is going to push the contents of the stomach up and out. Understand that the bag valve mask usage, the protocols are that it is a two-handed technique. One hand holds the mask against the nose and mouth, while the other hand ventilates. Ideally, two people will do this. One person with two hands will seal the mask, while the other person gently, meticulously ventilates the bag portion of the BVM. Let's watch this demonstration.
Providing positive pressure ventilation with a face mask and a bag valve device can be a life-saving maneuver. Although seemingly simple, the technique requires an understanding of the airway anatomy, the equipment, and the indications. Developing manual skills is necessary to provide adequate face mask ventilation. While endotracheal intubation is frequently the definitive airway management approach for patients in respiratory failure, it is not always feasible. In these circumstances, ventilating a patient with a face mask can be an invaluable temporizing measure. The purpose of this video is to demonstrate the equipment and technique used to provide positive pressure ventilation with a face mask and a bag valve device. Face mask ventilation is used in patients with respiratory failure but who are still spontaneously breathing and patients with complete apnea. Face mask ventilation can be indicated after the induction of general anesthesia, the administration of neuromuscular blocking agents, narcotic overdose, cerebrovascular accidents, cardiopulmonary resuscitation, and other situations in which spontaneous breathing is failing or completely ceases. Face mask
So remember, looping back to the protocols and recommendations for using a BVM, one person using it alone, it's difficult to manage, especially in a moving vehicle or boat. Maintaining that mask seal, especially in a wet environment or if the person vomits, makes it very difficult. Realize you're only ventilating until you see the chest rise. That being said, the best practice protocol is to have 2 people managing the airway when you have enough personnel. One person maintains the seal and the position in that head tilt chin lift, while the other person gently and meticulously ventilates the bag of the BVM. As an important review of some of the techniques for smaller size patients, children and pediatrics, remember that especially in babies under 1 year of age, we are not doing an exaggerated head tilt chin lift. The protocols in your AHA class stated sniffing position, just the nose up position so that you don't collapse the trachea. These infants or pediatric patients under the age of 1 have not developed the tracheal rings as of yet, and so if you overbend their neck, the trachea will collapse, causing an airway obstruction. An open airway in that age of a patient is just the sniffing position. Also realize that the older the patient, especially in an adult, the reason that we need the head tilt chin lift is to move the heavy, large tongue out of the posterior pharynx. Infants don't have a large, heavy tongue. It's basically the size of an adult thumb. So the sniffing position is enough to maintain and open the airway. Remember again, you're only squeezing enough to see the chest rise and not more. Just a diagram showing that again, if you take a flexible straw, you can gently bend it, but once you go a certain threshold, it will collapse. That's what we were talking about when we mentioned not hyperextending the neck of a pediatric patient, because you will collapse their trachea. Very important to understand some of the anatomical differences in a particular patient. Some patients have had laryngeal surgery for pathology, cancers, or trauma. These patients may have a stoma or an opening in their neck. If you have a patient during the summer that's wearing a turtleneck, most likely they are covering that stoma and allowing the turtleneck to act as a filter. So look for that in your patients. In these patients, you have to close their nose and mouth with one hand while you place the face mask of the BVM over the hole to ventilate. Obviously, this takes multiple hands. So again, 2 rescuers for ventilations are going to be key for those patients with a stoma. Again, there may be multiple adjuncts to help maintain airway from the mouth to the lungs. You may see some of these devices used by the paramedics. Just important to understand what they are. We will be using BVMs. The EMTs may insert an oropharyngeal or a nasopharyngeal airway to help lift the tongue off the back of the throat, while advanced practitioners will use an LMA, laryngeal mask airway, combi tubes or intratracheal tubes, and other advanced airways. Let's watch this video demonstrating intermediate and oropharyngeal, nasopharyngeal airways.
Before beginning face mask ventilation, it is prudent to examine the patient's oral cavity when possible. Smaller dental prosthesis or other foreign bodies can be swallowed or aspirated. One may consider leaving full dentures in place to provide a better mask seal. The most common method to hold the mask consists of placing the thumb and index finger on the body of the mask, while the other fingers pull the jaw forward and extend the head. The middle and ring finger are placed on the ridge of the mandible. and the fifth finger is placed behind the angle of the mandible. The tongue is the most common cause of airway obstruction. It is important to minimize the pressure applied to the submandibular soft tissues, as this may further obstruct the airway by pushing the tongue against the palate. Maintaining an adequate seal while extending the head, thrusting the jaw forward, and squeezing the bag with the other hand may require considerable manual strength and coordination. Extreme caution is advised in patients with cervical spine injuries, in which flexion or extension of the neck is contraindicated. In this situation, the jaw thrust maneuver alone, without head extension, is recommended. It may be difficult or impossible to maintain an adequate seal using only one hand. This challenge can occur in obese or edentulous patients, or in those with abundant facial hair. Additionally, large patients may present a challenge for individuals with small hands or with insufficient manual strength or dexterity. In these situations, the mask can be held with two hands, with each hand positioned as described in the one-hand technique. A second person compresses the bag valve device. Regardless of the technique used to ventilate the patient with a face mask, adequate ventilation can be assessed by inspecting and auscultating the chest and abdomen. The chest rising and falling and breath sound synchronous with the delivered tidal volume suggest adequate ventilation. Gurgling epigastric sounds and tympanic abdominal distension indicate gastric insufflation and poor ventilation. Other monitoring tools such as pulse oximeter and a carbon dioxide detector can be very valuable. Occasionally, it is difficult or impossible to provide ventilation unless an oral or nasal airway is inserted. These devices are most helpful when the cough and gag reflexes are absent. Insertion in patients with intact reflexes may precipitate coughing, vomiting, and laryngospasm. When used, the appropriate size device must be selected in order to avoid worsening of the airway obstruction. Too small an oral airway may push the tongue against the oropharynx. Too large an oral airway may push against the epiglottis and trigger laryngospasm. The correct size of an oral airway may be estimated by holding the airway next to the patient's mouth. The tip should reach the angle of the mandible and no further. An oropharyngeal airway can be inserted by depressing the tongue with a tongue blade and advancing the airway towards the base of the tongue. Alternatively, the airway can be inserted upside down and then rotated 180 degrees as it is being advanced posteriorly. In general, nasopharyngeal airways are better tolerated than oral airways when airway reflexes are present. They are particularly useful when the mouth cannot be opened. The simplest method of estimating their appropriate length is by correlating it with the external anatomy of the face and neck and taking into consideration the patient's height. Nasopharyngeal airway should be thoroughly lubricated and advanced perpendicular to the face and parallel to the floor of the nose, not towards the roof of the nose. They must be used with extreme caution in patients with facial injuries, basilar skull fractures, and coagulopathy, weighing the risk of further injury and bleeding against the need for oxygenation. Raising the head of a bed may facilitate the delivery of adequate tidal volumes, but may be contraindicated because of hemodynamic instability, or may be impossible, for example, if the patient is on the floor.
The oropharyngeal airways in our kits for our EMT practitioners. They do come in different sizes. As you saw in the demonstration, the appropriate size is measured from the corner of the mouth to the earlobe and then inserted. Once again, they do come in multiple sizes. Once placed, the oral airways, depending on their design, have channels on the sides or in the center. That is to allow better suctioning as well, because you can pass a French suction or rounded thin suction through that opening in order to facilitate suctioning while the oral airway stays in place. Outlining the sizing process, again, from the corner of the mouth to the earlobe. These airways are called adjuncts because they are an adjunct to the head tilt chin lift. They help Additionally, support the tongue out of the back of the throat, maintaining and opening the airway more than just by head tilt, chin lift. Now, for the sake of completion, talking about the nasopharyngeal airways. As an airway adjunct, these devices are moved into a position and measured to the position where they help hold the tongue from the oral pharynx. These devices should be used with lubrication in order for them to advance easily through the nasal cavity. For the sake of simplicity, these devices will be measured from the nares to the earlobe. As mentioned before, significant precaution has to be taken in mid-face fractures, because as you advance the airway, you may cause damage to the inner structure of lacerations within the nasal cavity or the base of the skull. Let's look at some pointers in helping ventilate a patient.
When the patient is breathing spontaneously, one must synchronize the delivered tidal volume with the patient's inspiration. Regardless of the presence of spontaneous respiratory effort, when excessive pressure is delivered to the airway, gastric insufflation may occur. This may lead to a vicious cycle of increased intra-abdominal pressure, which requires higher peak inspiratory pressure and can result in further gastric insufflation. This not only reduces effective ventilation, but predisposes patients to vomiting or regurgitation. Complications other than the inability to ventilate can occur, including corneal abrasions and blindness in the presence of a severe eye injury. Soft tissue injuries, particularly to the bridge of the nose and lips, may result when excessive pressure is applied. Complications such as trigeminal and facial nerve compression have been reported due to continuous.
As always, everything we do is under the premise of do no harm. We have to be gentle when utilizing these type of techniques. Remember that when patients go unconscious, the muscles also reflexively go relaxed. If the muscle relaxes in the stomach and the diaphragmatic pressure and the sphincter open and relax, that will cause stomach up contents to move up the esophagus into the airway. Once again, be cautious with the amount of pressure that you put with the BVM. Only enough pressure to watch the chest rise. Times, dealing with an airway requires having suction available, especially in our cases with the high potential for drowning patients. Stomach contents are going to be key to manage and suction. We don't want to have someone on their back that's throwing up and ventilate them, pushing that fluid directly into the lungs. This will dramatically change their survival rate. Just a gentle look at the anatomy. When we suction, we want to measure the distance from the mouth to the ear on the outside of the face and not push the suction further than that distance. We may cause damage to the delicate airway structures beyond that point. So the suctioning is done only within that upper area, basically to the posterior tongue, and we don't suction on the way in. We place the suction and we suction on the way out. In helping our marine medics, they will have a different suction than what we carry. We are utilizing a manual suction because in our environment and inability to charge our suction units on the boat, it won't work to have electronic devices. We've tried that in the past and it hasn't worked. The marine medics will bring their charged units with them to shift. Important for you to ask them how to use it and how to turn it on and turn it off. Have them demo it for you. we carry a manual suction kit in each of our med oxygen bags. This device has a handle with a compressible grip that provides the pressure for suction, has a container that can take up to 300 cc's, and has two attached suction tubes, one that is 6 millimeters in inner diameter and the other that is 22 millimeters in inner diameter. Look at some key points in the technique of suctioning.
Prepare and turn on the suction device. Prepare and turn on the suction device. Assure the presence of mechanical suction. Insert the tip of the suction catheter into the patient's oropharynx to the base of the tongue, or only as far as you can see. Engage the mechanical suction by covering the hole at the base of the catheter. Suction back and forth while withdrawing the device, taking no more than 15 seconds.
The reason you don't want to suction for more than 15 seconds is because as you do, you're also suctioning out any available air and oxygen that may be in the airway. So we do short-term suctioning and then go back to ventilations and then suctioning again. As you can see, these techniques take a lot of effort and practice and teamwork. As mentioned, the protocols and algorithms for airway management ideally in best practices require 2 people to just manage the airway. This takes a lot of pre-planning and pre-treatment and training. Looking at your equipment, making sure that everything you need is there at the beginning of the shift, making yourself some cognitive aids to remind yourself of the steps that you'll need to move through as you go through your CPR algorithm, the CAB. Always being situationally aware, paying attention to how the patient is doing. You may be doing CPR on a patient that then has a pulse, but no respirations. Now what do? You may be doing CPR on a patient and they start moving around. They have a pulse and they start to gasp for air. Now what do? So your mission adaptability is key, but you can only adapt to things that you're situationally aware to. Again, if the patient starts to vomit, you have to stop and suction the airway. So maintain control and direction of your algorithm and the processes that you use. This only is possible with good practice. Doing CPR training once every 2 years is not enough. Remember, check all your equipment at the beginning of your shift, make any notations on equipment needs and any repairs, and make adjustments as necessary. We carry backups for our backups. We're prepared by meticulous training and reviewing techniques that you may have forgotten. In the end, don't panic. We all work as a team, and we're trying to do the best for the patient as possible. Be semper paratus. Again, thank you for your attention. Hope there was some learning that went on here and that you can retain some of the information you've learned. There are key factors to our references that reflect the TEMS protocols as well as the CPR protocols for the American Heart Association classes that you've taken. The best to you. Make sure that you look through your O2 kits at the beginning of your shifts. There are placards that show what is in each of the compartments. When you open it up, on one end you'll have C-spine precautions. In the middle you'll have your oxygen tank. You'll have oxygen delivery devices. You will have PPE. And you'll have your bag valve masks, including the rescue mask that attaches to it, and the accessory line that goes from the end of the bag valve mask to the oxygen tank. There'll be additional first aid and bleeding control elements within the kit. Trauma dressings, scissors, your CAT tourniquet, and additional trauma treatment aids for Stop the Bleed. This is an Israeli dressing. Your manual suction will also be in that kit. Thank you so much. The best to you. We'll see you on the water. Your training sergeant, Kriss Ghafourpour. Please feel free to keep in touch. Don't hesitate to email me at any time.